Yes, good evening, everyone. I would like you all. I would like to invite you all for the SWAC also 2023. I would like Dr. Vinay Singhal, Director Critical Care, Medical College, Medical Sciences, Ambala, to share his talk.
Uh, Dr. Ranajit sir, can you have
Yes,
some brief about the workshop
just
as a whole for
before
2 minutes?
we start our talk, to all the participants, it's a very good afternoon. In fact, evening now. Right in Delhi, the sun is setting, and we are here sitting here talking about one of the most serious subjects on renal replacement therapy, joined by all experts all over India. My very good friend Valentine Lobo joining from Pune. Vinay is joining. Dr. Vinay is the head of the Medical College there in Ambala. It's a great medical college coming up there, and is the head there, the Department of Critical Care. And I will be joining very shortly by Dr. Sunil Karan from Medicity from Bangalore, by your own PL Gautam. Dr. PL Gautam will be joining just from DMC, and Dr. Suman is already there. I think she has not yet joined. So our main aim today is to give an idea about exactly what is the background and the environment where we are going to start, where we're going to practice renal replacement therapy, especially continuous renal replacement therapy in particular. We are going to deal with the sickest of the sick patients, and we will be dealing with those patients. And that is the reason why continuous therapies becomes much more relevant, and because they can be easily handled by intensivists who are regularly working in the ICU. They can easily be incorporated in the ECMO circuits, and they've been done for the last 10, 12 years. And they can also be used as an undisputed leader in removal of the extra fluid from the patient compared to its intermittent counterparts. So our main aim is to focus on exactly our situation, what we are getting in our patients today, and followed by the workshop on 10th, so that it doesn't get intermingled in between. So don't want to add these topics there and waste our time, and that is the reason we are starting it today. We are exactly on time, and I will request Dr. Vinay Singhal, the head of the Department of Critical Care and of Medical College in Ambala. Dr. Vinay Singhal, my very good friend, and is doing a lot of CRRTs and ECMOs for years, and I think you'll be benefited from his talk. All right. Dr. Vinay, please.
Uh, Thanks, boss, and uh, very good evening. And I'd like to start, and we are thinking that how to start this workshop, as we are going to talk about the CRRT for a day, more than a day now, because we'll be having some talks here, and then we are going to have some uh, hands-on practice on the 10th of March at Ludhiana. So, what I thought that I'll start with the topic which enables us to assess the volume of the patient, volume status of the patient, and how to this may help in prevention of renal failure. So definitely, whenever we talk about the many of the patients who come to our intensive care unit, they are somehow or other behind fluid, and that might be the reason of this renal failure in many cases, and they are preventable if we do the timely intervention and start IV fluid therapy, resuscitate the patient timely. Then we can prevent these patients from going into the acute renal failure and further into the situation where we may need your renal replacement therapy. So prevention of renal failure, you can say that yes, how to prevent the renal failure. And there are many ways we are assessing the fluid status since ages. We are looking at the patients who are in shock, and then they are coming to us. So we are starting with a case, 63-year-old male with history of hypertension, obesity, and Patient is in heart failure with history of heart failure with the ejection fraction of approximately 24%, with complaints of loose stools, dyspnea on exertion, and abdominal distension. Patient is was already on carvedilol, lisinopril, nitrates, and hydralazine. And this patient on presentation had a heart rate of 65 beats per minute, blood pressure of 92 by 60 millimeters of mercury. Pedal edema was present, JP was normal, no S3, as normal S1 and S2 sounds were there, heart sounds were there, and chest X-ray was showing no evidence of pulmonary edema or effusion. And his serum creatinine was 1.4 milligram per deciliter. Baseline serum creatinine was approximately 0.6 to 0.8 milligram per deciliter for this patient. So we can see that this is a difficult patient in a way that yes, patient is definitely going into renal failure, and there is an acute kidney injury because we know the baseline creatinine also. And but because this patient is having a heart failure component, again loose stool, so we don't know the exactly this fluid status of the patient, volume status of the patient, and he's having heart rate of 65, but he's on beta blocker also. So there are so many things are there which are confounding. There are so many confounding factors. So your patient, you need to assess the your volume status. And so what's next? So we have to see that yes, this patient has definitely gone into renal failure. And if we look at this KDIGO criteria for acute kidney injury, this says that according to this functional criteria, serum increase by serum creatinine by more than or equal to 50% within 7 days, or increase in serum creatinine by more than or equal to 0.3 milligram per deciliter within 48 hours, or oliguria is there. So this patient is in renal failure, and this patient might have gone in this renal failure because of he's on drugs, he's on diuretic also. I think if I had not mentioned, I don't know. But again, this patient was on drugs also. This patient is having heart failure also. So and loose stool could be because of some infection, gut infection. So this patient is definitely creating some problems, and we have to see that yes, we need to give fluid. And if we want, so which fluid, what fluid, and how much of fluid, and and the first question will be that yeah, okay, if this patient at all requires a fluid or not. So the same paper had given some questions, research priorities for the fluid management and hemodynamic support. And if you look at the points for this fluid management and hemodynamic support, and this suggests that determine the optimal indications and targets for fluids and vasoactive drugs to improve kidney outcome in acute medical illness and in perioperative. So you have to assess that yes, if there is at all an indication of fluid therapy, or your patient requires some vasoactive drugs only. So determine the optimal vasopressors in this context. Investigate the optimal method of administering fluid for preventing or mitigating acute kidney injury, either by oral or IV route, and a bolus. Do we need to give bolus or continuous infusion of fluid? Rate, volume, and frequency. Everything we have to look for this patient. So again, we had to investigate new technique to detect fluid overload in adults from this defined fluid overload thresholds to guide management decisions. In addition, determine how fluid removal should be optimally accomplished, including the method, rate, targets, and so basically, we have to see that we have to look at the ways by which we identify if this patient is in fluid overload or fluid deficit, and our patients are in fluid overload or in fluid deficit, and then we have to look at either we want to give fluid or we want to remove the fluid, and then again we have to decide about the rate of removal of fluid. If these patients are going to respond to diuretic, or if these patients if or not responding and we want to remove the fluid, then other renal replacement or stop or something like that, if we are going to do all this. So we are going to discuss all these things during this whole workshop. And uh, uh, again, we have to understand that assessment of fluid and hemodynamic status is a critical skill and central to almost every disorder related to the management of PKI. So, and fluid status assessment tools which we used to use by like jugular venous distension, third heart sound, rails, peripheral edema, they have a poor sensitivity because as I said initially also, that we have these things are time bound. So we have to understand we should not lose this precious time, and when we actually hit, when we can actually hit the patient, and we can actually save the patient from going into the pre-renal to actually acute, going into the frank acute kidney injury. So you should understand this time-bound management of the patient, and like everything we had seen, like in cardiac MIs, your patient is coming with the with once we start with CPR after the cardiac arrest. Again, everything you see that depends upon the time. If we intervene at the right time with the right intent and the right method, you can prevent some unwanted events. So just to show that yes, there is a hypoperfusion, and there may be patient may be in shock, there may be hypotension, then we have to monitor look at the cardiac output, if it is normal or high or it is low. And if it is normal high, then it is a distributive shock, and if low, then we have to look at the CVP or pulmonary artery wedge pressure, if it is high or low. And here you can see in every window, every limb, how you can assess the things is by the echocardiography. So your physical examination by when we used to look at the pulse and blood pressure only, or we want to see the CVP, or we want to see something else, we have to understand now the point of care ultrasonography has taken a big space in the intensive care assessment and management of the patients. That includes fluids therapy also. We have so many gadgets initially for hemodynamic monitoring, but the first gadget, if you are starting a new ICU, then you want to have is your definitely an ultrasound machine in your intensive care unit. Other windows, other parameters which you can by which you can assess the fluid status is like your lab parameters. You can look at the lactate. If your patient is having high lactate, it means your patient is in shock definitely. May not be, I don't know if we can really say that hypoperfusion status is definitely there, but again, it will not tell you about your fluid status. That same is the, again, peripheral perfusion, markers of peripheral perfusions like skin temperature, mottling, capillary refill rate, altered mentation where it shows the decrease. So all these are the features of shock, but doesn't tell you exactly, but that yes, and even if once they are present, it is very late parameters when actually they can tell you about that yes, your patient is in fluid depletion or something like that. So key components, if you look at the sonographic evaluation of the fluid volume status, then how this sonography or point of care ultrasound has assisted our hemodynamic assessment or fluid status of the patient. So what we can do, this one probe can do, you can do the lung ultrasound, you can do the focused cardiac ultrasound, you can look at the inferior vena cava, you can do the hepatic vein Doppler, you can do the intravenous venous Doppler, portal vein Doppler. All these things you can do by your probe, and you can do the hemodynamic assessment and see that your patient is in fluid deficit or not. So lung ultrasound, how do we see the lung ultrasound? Lung ultrasound is there's a normal lung ultrasound where you can see the A lines are present, and they are the artifacts of this pleural reflection, and you can see these lung lines in a normal lungs. Here are the B lines, and you can see these arrows. They are showing the vertical lines. B lines are present in the lung. So again, it indicates interstitial edema. Here again, it's further the lung is solidified or something like that, or hepatization is there, then it is like consolidated lung here, and here you can see the pleural effusion. So you can see this lung ultrasound. This is normal, and this is a condition where you can see the fluid overload. And in fact, we do the volume resuscitation, and if you say, they say that once you see that B lines are appearing in the lungs, you can stop further resuscitation. So we used to use, and before this ultrasound, if we see that yes, patient SpO2 is falling, then you stop giving more fluid. So here we can diagnose the things one step before once we give the fluid resuscitation and fluid status of the patient. Cardiac ultrasound, we can see that pericardial, here we can see the pericardial effusion. We can see that definitely we can see the chamber size, and if there is a anteroposterior wall of the left ventricle is kissing, then it is definitely a fluid deficit. Or if we see the distended LV ballooned out left ventricle, then again it could be that yes, left ventricle is full, and it can be because of many reasons. And again, if we here we can see that flattening of interventricular septum, and you can see that LV is compressed. Here again, in some condition, here you can see that your IVC is distended like anything. So again, your patient is having full IVC, and you will see that why should I give fluid in this patient? And you should have a valid reason of giving fluid, even if you see this kind of inferior vena cava in your patient. And here you can see that yes, your IVC is compressed over here. Coming to the hepatic and portal venous Doppler, ultrasound Doppler, and here you can see that your IVC, and in this view, you can see that yes, in the long axis, and your probe is here subxified position, and here if you see in the long axis, you can see this IVC, and you can see the hepatic veins, and if you rotate it, and in the transverse axis, you can see the IVC as a cross section, and then you can see the hepatic veins coming and draining into this IVC. And again, if you want to identify the portal vein, and then you have to see that scan it from the anterior axillary line initially, and your probe is here, and you can see that this is the portal vein, and this portal vein is usually showing a pulsatile flow, and increase in the pulsatility of portal venous flow has been associated with a higher anti-proBNP, higher systolic pulmonary artery pressure, positive fluid balance, and RV dysfunction. So we can assess so many things by just putting one probe on the patient, and it doesn't take much of the time. And these things will definitely, I will not say that you should use these parameters or these monitoring devices as a standalone devices, and don't look at the things of clinical history of the patient and assessment of the patient is equally important. And once you assess the patient along with the history, if you're getting the telltale signs, other telltale signs, and once you put your probe and your probe is also suggesting your ultrasound monitor and your findings are also suggesting the same, then you can definitely say, yes, I need to see that, yes, my patient is either fluid deficit or fluid or fluid is fluid overloaded. Your patient is. So, timely assessment of the volume status is critical for the critically sick patient or borderline patients who had come to you who are not sick right now, but if you don't intervene in a time dependent manner, then they can become very sick. They can have hypotension. They can go to the acute kidney injury, and they can have a multi-organ dysfunction. Physical examination is limited in determination of fluid state. Sometimes they give us they are the delayed signs. So sometimes if we see that, yes, once your patient is in hypotension or once the Crrts are already there in the lungs, they are all the late sign of the fluid status. So we have to fluid overload or fluid deficit. There are delayed signs of all these things. And so we have to see that, yes, our ultrasound is helping us in monitoring these patients in most of emergencies and the intensive care unit. So we should use them to the fullest and look that how they can best help us in monitoring the status, determination of the fluid status. Augmented examination using focus or point of care ultrasound is gaining popularity as a non-invasive. The big thing is that it is non-invasive bedside tool that provides a detailed insight into cardiovascular physiology and hemodynamic determinants of the fluid status. Thank you very much. Thanks. Any questions?
Thank you, Dr. Vinay, for such a wonderful lecture and describing the ultrasound and its use in our clinical practice. Any questions from anyone?
Any comment, boss? Dr.
Well, it was an excellent lecture, Dr. Vinay, and you have not only the timely assessment of volume status, but also you have shown how exactly we should be disciplined and timed in our lectures out here. You exactly completed in time, and you have shown most of the ultrasound, the way is a very simple way you have shown it. And basically you're passing the message that, yes, we have to use more and more ultrasounds by the bedside, by the clinics, so that slowly and steadily we get our dynamic measurements properly done by the bedside. We become well conversant with it. That is the message that you want to pass. Excellent one, Dr. Vinay. I always love to listen to you, and I hope that I will also complete in time this time. And yes, Dr. Gurkirat, you can continue.
Yes, sir, Dr. Ranjit, now I would like to invite you for your talk on acute kidney injury in the ICU. He is the head of critical care in Swami Dayanand Hospital, Delhi. Good evening, sir. Yes, sir, please.
Good evening, and I don't think that if my laptop is having some problem, I don't know why. You have to. Can you see my slides?
Yes, sir.
Can you see the slides?
Yes.
All right. Can you see the third one, fourth one?
Yes.
All right. So let me keep it here only like this, because I can't make it full screen, because with full screen it doesn't move. Just I'm making it once. Is it moving in the full screen?
Okay, sir. Just try.
Now you can see management of fluid and electrolytes, the first slide. I have gone to the second slide. Can you see the second slide?
No, sir. No, sir.
All right. So let me go to this one only, and let me keep it here. I think everybody can see it. There is no problem. So, yes, my dear friends and my colleagues, so today the topic is management of fluid and vasopressors in sepsis beyond septic guidelines. This is basically the topic. And without wasting any time, I'll just start with this great man. Many of us may not be knowing the name of this man, this Thomas Atkinson Latta. He is basically the first person who introduced fluid in modern medical practice way back in 1832. He started giving fluid to a patient who was suffering from cholera. That time the patient used to die miserably with cholera. We only had some codeine or other opioids to basically cause some amount of, we tried to do, the medical community tried to do some amount of constipation in these type of patients by giving codeines, but they used to fail miserably. Nobody knew it's basically you have to give fluid because there was a lot of fluid coming out. And Thomas Atkinson later first started the fluid in way back in 1832. The patient survived for a few hours, but when he went home, his house surgeon didn't know exactly what was happening. He didn't explain it well to his house surgeon. He removed the fluid and the patient died. But that was the first time the fluid was used, and the composition of the fluid has been given here. Since then, we are deciding on fluids, but we are still not sure exactly which fluid has to be used, especially in patients who are suffering from septic shock. If a patient comes to you with septic shock, we know that we have to give fluids. This is the first thing that we know. And this recommendation has been given through ages. And since the Surviving Sepsis Campaign has come out with the latest one, but see the recommendation they're giving. Still, after so many years of fluid use, Atkinson letter must be smiling from heaven that yet you people have not yet decided which fluid has to be given, and still you are giving a recommendation of weak recommendation of low quality evidence regarding crystalloids. We know that we have to give crystalloids by now, though there is again some controversy with it. How much crystalloids that have to give? 30 ml per kg body weight. Again, this is a suggestion that has been taken from 3 studies. That is the Arise, Awake. These studies that came up, those I always say is Arise, Awake, and Stop Not Till Your Goal is Reached. Like that, 3 studies came up after the reverse trial. And from those 3 studies, from Australia, from England, and from USA, they came out into a conclusion that I'll give 30 ml per kg. But is this 30 ml per kg absolute for everybody? It may be too high for patients with CHF or for CKD patients. It may be too low for the patients who are in GI sepsis. And we have given with an arbitrary time frame of 3 hours. So the point is, this 30 ml per kg that has been given in the guideline has to be re-evaluated, and it has to be individualized according to the patient's situation. Maybe in patients who are suffering from pneumonitis with sepsis, they may not be needing that amount of fluid. We might start with a lower amount of fluid, maybe about practically saying about 10 ml per kg body weight for the first 1 hour, 10 to 15 ml per kg body weight. And then we have to decide whether to start on vasopressors or not, and how to start on vasopressors. That will be coming next. So this is the part where you have to go beyond guidelines, and you have to study to individualize whether to give a bit more or a bit less fluids in these patients of septic shock who are presenting to you different etiologies. Now, for example, the fluids, crystalloids, this is a strong recommendation that has been given. Now they gave a very weak recommendation about the balanced salt solution instead of normal saline. Now, when they gave this recommendation, only the SMART trial was there and the SALT ED trial was done in non-critical patients. On the basis of this, as the balanced crystalloid showed that with normal saline, it was seen that the major advanced kidney events MAKE at 30 days was a bit more, significantly more than that of balanced crystalloids in the SMART trial. They went on suggesting that let us use balanced crystalloids. Now, after that, 2 trials came, one from Brazil, that is the BASICS trials, and the PLUS trial. Both of these trials showed no difference between balanced crystalloids and normal saline, especially in patients of septic shock. Now, what to do? So again, we have to individualize our patients. We have to see there are certain patients definitely where you might be needing balanced crystalloids, but most of our patients where initially the 10 to 30 ml per kg body of normal saline is not going to make that much of difference in your patients, especially in countries like ours where a balanced salt solution costs you around 200 rupees, whereas a normal saline costs you around 18 rupees. You have to rethink about our patients. Now, this is about the typical type of crystalloids that we are having. Now, I'm not going into the removed from our practice. But the first trial, which showed better lactate clearance, less renal injury, less fluid management, no mortality difference in trauma, The Christmas trial, which didn't only show that there is no adverse effect and less volume is required, and the Crystal trial, colloids versus crystalloids, where increased mortality was seen with the crystalloid group. These trials are not taken into consideration, citing certain irregularities. So now it is up to you to decide whether to use colloids or not. Till date, the guideline says better to use crystalloids, not to use colloids. Ultimately, you are the best judge to use it in your patients. Now, once I have given the fluids, maybe 10 ml per kg body weight, should I wait giving up to 30 ml and wait whether the blood pressure is coming up, or we should start vasoactive agents? The point is to start it early. When to start it, basically? So it's just go and see the diastolic blood pressure. If the diastolic blood pressure is less than 40, that means you have a huge peripheral vasodilatation. So that is the time there is no meaning of giving fluids, because they'll get again accumulated in the vasodilated capillaries and the vasodilated arterioles. It is always better that you start giving vasopressors, which basically start decreasing the diameter of these blood vessels. And so we start it the moment we see that the diastolic blood pressure quite low. We think of starting norepinephrine. Till 2008, dopamine was the choice. 2010, certain studies came up, like the SOAP trial, so by SOAP indicators by Daniel D. Baker. They showed that norepinephrine is better than dopamine because dopamine causes a lot of tachycardia, tachyarrhythmias, residual gangrenes, and increased mortality. And they found that you have to use norepinephrine, maybe up to 0.5 microgram per kg per minute, not more than that. But in resource-limited settings, the guideline still says that if you don't have anything, just don't wait. You have to start adrenal or dopamine. Dopamine now in modern clinical practice is only having one indication, that is hypotension with bradycardia. So if you are having hypotension with bradycardia, so that is where you might use dopamine. Otherwise, the first drug of choice is norepinephrine. Now you have started norepinephrine, you wanted to achieve a mean arterial pressure of less than 65. Because you don't have a central line, maybe in the middle of the night, your resident who is not so much accustomed to putting a central line is there. So what should you do? Should you stop, wait for the central line to come and then start? So the guideline says don't wait. At least start it as quickly as possible, but let maybe within a couple of hours, maybe 4 hours, try to put the central line and then try to convert it, try to give it through the central line itself. Look at the diastolic blood pressure. Still the diastolic blood pressure is less, mean arterial pressure is less, you start the second one. What is the second one? That is the vasopressin. Give by a dose of 0.03 units per minute, not more than that. Though the Vanish trial has used it up to 0.06 units per minute compared with non-adrenaline. These two trials, the VAST trial and the Vanish trial, they basically showed that vasopressin is a very good alternative, maybe after norepinephrine, to improve to do vasoconstriction in these type of patients. And even if you are not reaching your mean arterial pressure with the two drugs, you can add a third one, maybe epinephrine. So these are the guidelines, but again, not to cross the norepinephrine dose point, go on increasing it eternally. So don't do that. Add vasopressin to it as quickly as possible when you are reaching the ceiling. So still after this vasoactive agents, you have not yet reached your blood pressure target. So basically what to do? So this is the time when you start your steroids. Maybe after the first 4 hours, when your norepinephrine has already crossed 0.25 microgram per kg per minute, or it is going beyond that, your blood pressure is not coming up. You have also added vasopressin in between. So this is the time you add your steroids. So add your steroids. Again, assess your patient with dynamic parameters. See, you have to give a bit of fluid to the patient or not. Try to use your vasopressors properly, and then try to achieve your mean arterial pressure as quickly as possible. Though you don't know whether achieving this mean arterial pressure is going to increase your microcirculation or not. So we are not going to discuss microcirculation here. We are up to the mean arterial pressure, up to the vasopressors in the fluids we'll be discussing. So this is the chronology how we move on. Now, once you have achieved your mean arterial pressure, so now still you see that your cardiac function, your cardiac index is not good. So that is your cardiac dysfunction is there with persistent hypoperfusion. Now, it is very easy to say persistent hypoperfusion by the bedside. How to see that persistent hypoperfusion? Everybody of you may not be having ultrasound. Even if you have ultrasound, you may not be so conversant with their echo. If you are having an echo, it's very good. I have shown you the echo. You have seen the ejection fraction of the patient. The cardiac output is so less out there. So once you achieve your mean arterial pressure and you have an adequate volume status, then you think about starting an inotrope if your cardiac function is still not adequate. So another very easy way of seeing this one is to see the delta PCO2, the difference between the venous and the arterial PCO2. If this is rising, maybe more than 6, 7, 8 is going up, that means your patient is not, your cardiac dysfunction is still there. The CO2 is not being taken out properly. So this difference will help you in telling you, yes, now this is the time I might have to start an inotrope, maybe dobutamine. Levosimendan has been used, but it has been found of no benefit other than dobutamine. Remember, if you have achieved your mean arterial pressure, and the two other corollaries would have been will be icing on the cake if your SCVO2 and your hematocrits are more than their normal values. That is more than 70, more than 30. This is the time when you think of using dobutamine. This is akin to that of the reverse trial, except for the delta PCO2 part. Reverse taught us basically how to be very, very disciplined. So discipline was taught by reverse, and that discipline we are maintaining, and that is the reason why the 3 trials that came up that showed no difference in fluids if we follow early goal-directed therapy or not. Only reason being that over the last 14 years, from 2001 to 2014, we basically got disciplined. So, my dear friends, discipline is so much important in sepsis. To start it in time, to monitor it properly, and to use your vasopressors adequately. And once you have achieved your vasopressors, the question always comes, how to wean it off. There are different trials has been seen. Somebody says start weaning with the first one, non-adrenaline. Some says with vasopressin. If you ask me, I'll say you have increased your non-adrenaline dose from a lower one to a higher one, whereas your vasopressin dose is fixed. So it is better to stop the vasopressin first, which is having a fixed dose, and then slowly start on your non-adrenaline part, which is your first choice of vasopressor. Definitely, there is a lot of scope of research work on this. You can go on doing research on exactly how to stop your vasopressors. But the whole thing is the discipline that you have to follow. And I'll give you a very simple take-home message on this. Give your fluids early and adequately, and individualize it. And I've already told you in the first slide, maybe a bit more with the GI sepsis, maybe less with those with pneumonias, with those who are having CHF or in CKDs. Start non-adrenaline early. Don't wait. Use arterial tone when the arterial tone is assumed to be low. For example, the diastolic blood pressure, very easy to be by the bedside, less than 40. Start from the peripheral line. If your central line is delayed, start. But try to put your central line as quickly as you can. Customize monitoring your resources. Prefer non-invasive techniques as told by Dr. Vinay. Echo, ultrasound, passive leg raising to predict septic shock. Fluid responsiveness and resuscitation as possible overload can be seen with these things. And you can use the ETCO2s. You can use your pulse pressure difference of more than 15% by the bedside. It can be done anywhere. You can do it in Sundarbans also. Even if you don't have anything, if you accept a blood pressure machine. You can say your patient is fluid responsive or not. And a vasopressin should be added. Don't cross non-adrenaline's limit. Add it quickly and consider PCO2 gap to see the adequacy of cardiac output in cases of sepsis where SCVO2 and hematocrit is within normal range. If you don't have the expertise of seeing the cardiac output, or you don't have ultrasound with you. So here I stop. I think I'm in time. I am following Vinay. And stop sepsis, save your lives, my dear friends, and thank you so much for your patient hearing. Thank you.
Thank you, Dr. Chatterjee, for enlightening us with the fluid management and the vasopressors. And you did finish your talk in time, and we are thankful that prior to your commitment also you have attended us very nicely. Now, any questions from anyone? Dr. Vinay, any questions?
No, I don't think there is any question from the. Please, I request participants to please
Yes, sir, there are no
type
questions
in questions in the chat box. And very
in
nicely
the chat box.
presented, Dr. Chatterjee, and summed it up very well. And I think we can go with the.
Yes, sir. Now I would like to invite Dr. Valentin Lobo. He is a consultant nephrologist in King Edward Memorial Hospital, Pune. He'll be speaking on acute kidney injury in the ICU, definition, diagnosis, management, and how to assess bedside. Dr. Valentin, welcome, sir.
Thank you, ma'am. Let me try to share my screen.
Yes, sir. Yes, sir, your screen is visible, sir.
Visible, right.
Yes,
now
sir.
I'm going to full screen.
Okay, sir.
And is it moving?
No, sir. No, sir.
1 minute. Now can you see the second slide?
Yeah, we can see, but it's in the small screen only.
Okay, now I've made it full screen.
No, sir, it's coming in small screen. I think we can adjust with that.
Okay, fine.
Okay.
So then let me start in that case. So following Ranjit and Vinay, what they've done is to tell us how to manage fluids and how to manage sepsis. When we are unsuccessful in managing fluids and sepsis the way we should be doing, then we would end up with acute kidney injury. Now, back in 2004, the ADQI first realized that we were making a mistake when we used the term acute renal failure, and they changed this to acute kidney injury with the realization that it was necessary to act early, to act when injury occurred and not failure. And in 2012, the KDIGO standardized the definition for us as acute kidney injury being an increase in serum creatinine by 0.3 milligram per deciliter within 48 hours, or an increase in creatinine to 150% in a period of 7 days, along with or without a urine output that was less than 0.5 ml per kg per hour for 6 hours. Now, this is a summary of what the definitions were. Rifle told us, the Rifle classification told us that a creatinine increase of more than 50% over 7 days. The Akin shortened that down to 0.3 over 48 hours, and KDIGO in essence combined the two to tell us that it could be either an increase in the serum creatinine by more than 0.3 or in 48 hours, or 50% over a period of 7 days. In addition to giving us definitions of acute kidney injury, what all these three systems did was to classify or stage acute kidney injury. So in Rifle, we had risk, which corresponded to the Akin and KDIGO stage 1. We also had injury, which corresponded to the Akin and KDIGO stage 2. And then we had failure, which corresponded to stage 3. The important difference was that and Ranjit made a reference to this when he talked about the CHESS trial, what was realized was that when you looked at patients who required renal replacement therapy, then irrespective of the Rifle stage to which they belonged, the mortality was higher if the patients needed acute kidney injury, reaching in one study as high as 75%. So what Akin and KDIGO did was to incorporate this and say that if a patient needed renal replacement therapy, then they would automatically go into the most severe category, that was stage 3 of acute kidney injury. In addition, they removed the two outcome measures of what were called loss, which was at 28 days, and end-stage kidney disease, which certainly should not have been considered as acute kidney injury. In 2017, the ADKI came up with, they tried to bridge the gap between acute kidney injury and chronic kidney disease, which was a disease that persisted, a raised creatinine that persisted for more than 90 days. So in that period of 7 to 90 days, if the patient had an elevated serum creatinine, ADKI told us that this group would not be acute kidney injury or chronic kidney disease, but coined the term acute kidney disease to describe this group of patients. They also classify.
Slide not moving.
Okay, then I'll have to. Now, which slide can you see now? Is it the one on acute kidney disease?
Yes, sir.
Okay, so I'll have to keep it like this, just as Ranjit did. Let me see if I can. No, that's not good enough. Okay, is it the? Okay, is this moving now?
Yes, sir.
Yeah.
Yes, it's moving, sir.
Yeah. So the ADKI group also staged acute kidney disease depending on the degree of elevation of serum creatinine above the baseline. They staged it as stage 1, 2, or 3. And if it was less, it was between 1 and 1.5 times the baseline. This was staged at stage 0, where the creatinine hadn't returned to baseline. The stage 0 was also subclassified as stages A, B, and C, depending on the presence or otherwise of ongoing kidney injury as measured by biomarkers which were more sensitive than the serum creatinine and the urine output. A validation of the urine output and serum creatinine criteria for acute kidney injury came from this very large study of 32,000 patients in 8 ICUs by John Kellum's group at the University of Pittsburgh Medical Center. What they did was to class the patients into groups which had no evidence of acute kidney injury either by urine output or serum creatinine criteria, the group which met the urine output criteria for acute kidney injury, the group which met the serum creatinine criteria, and the groups which had both urine output and serum creatinine criteria. When they looked at hospital 30-day and 90-day mortality, if there was no acute kidney injury, the mortality was in single figures between 5 to 7%. When there were only the urine output criteria were measured, the mortality jumped up to 12 to 20%. And when the serum creatinine criteria, it was 16 to 22%. But most importantly, patients who had met both urine output and serum creatinine criteria for acute kidney injury, the mortality went up to a whopping 32% at around 30 days and 90 days. And at 1 year, it was almost 50%. So clearly, patients who had acute kidney injury by both urine output and serum creatinine did worse than either patients who had no acute kidney injury, but also importantly, than patients who had only an either or, the urine output or serum creatinine criteria alone. There are some limitations, and that was to be part of what I was supposed to cover. If we have validated the serum creatinine and urine output criteria, but we need to realize that there are also some limitations. Drugs like trimethoprim and earlier cimetidine interfere with the tubular secretion of creatinine in the absence of acute kidney injury. They lead to a falsely high serum creatinine and perhaps a misdiagnosis of acute kidney injury. Similarly, this can happen in patients who take a large amount of cooked meat, which can give a rise to creatinine. Obese patients have a higher than expected serum creatinine, or in patients who have a reduced production of serum creatinine, the serum creatinine may be falsely low and the diagnosis may be missed. This typically may occur in ICU patients with severe sepsis or liver disease or undernutrition as a result of their underlying disease condition. Pregnancy is a physiological condition, and this is in fact one condition where the KDIGO criteria for acute kidney injury have no longer been validated, because in pregnancy, the normal serum creatinine during the second trimester drops by as much as 30 to 40% from the baseline, and so an acute kidney injury can be missed in this situation. There are drugs like cefoxitin which interfere with the measurement of serum creatinine by the Jaffe reaction, as does endogenous bilirubin. If a patient is fluid overloaded, the serum creatinine will be diluted because the total body water has been increased and give a false low reading. And of course, oliguria may occur as a result of postoperative pain due to the secretion of the antidiuretic hormone. So if serum creatinine and urine output have limitations, then became a search for various other biomarkers. And we've had a lot of them, and I cannot go into, for reasons of time, into all the details of cystatin C, calprotectin, alpha-gluterin transferase, hepcidin, which we did some work on ourselves, the liver kidney binding protein, the fatty acid binding protein, kidney injury molecule, interleukin 18, and the most studied of all is the neutrophil gelatinase associated lipocalin. But the question we might ask ourselves is, what is the importance of looking for a biomarker beyond serum creatinine and urine output when no guidelines tell us about any action to be taken other than when we are looking at creatinine and urine output? Well, a seminal study on this was carried out by Michael Haas and published about 12 years ago. Now, what Haas did was he had a group of patients who had normal NGALs and normal serum creatinine and therefore could be considered not to have acute kidney injury. The mortality in this group, like in all other studies, was extremely low at about 4%. Now, if the NGAL, which indicated tubular damage, was elevated, though the serum creatinine was not, the mortality rose up to about 12% and the need for dialysis to about 14%. This was significantly different from patients who did not have acute kidney injury, while patients who had a normal NGAL but a serum creatinine which was raised had much better mortalities and the need for dialysis, and in fact was not significantly different from patients who had a normal serum creatinine. However, when patients had both evidence of an elevated tubular marker like NGAL as well as serum creatinine, the mortality went even higher, as did the need for dialysis. So based on this, we today have a subclassification, and we have recognized that there is a group of patients in whom tubular damage or other evidence of renal injury is present, and we call them subclinical AKI. Because loss of function has not occurred, these patients may have a normal urine output and a normal serum creatinine, but evidence of tubular damage akin to the very similar to the group of patients who have elevated cardiac enzymes, but perhaps do not have cardiac failure. In addition, we have a group of patients who have an elevated serum creatinine, but without evidence of tubular damage, and this group fits what we have known for many years as pre-renal azotemia. And of course, the worst group is the patients who have both elevated tubular markers as well as serum creatinine. Acute kidney injury is not a single disease. It's a loose collection of syndromes with various etiologies, but we tend to group them all together and treat them all in the same way. And our traditional markers of acute kidney injury, serum creatinine and urine output, do not distinguish between these groups of patients. So it's important to know whether we can find markers which will enable us to make this distinction. We think of ischemia and volume depletion as a continuum. It starts with volume depletion, and if the volume depletion is severe, there's organ ischemia. However, when studies were carried out, volume depletion induced metabolic pathways and anti-inflammatory markers, while ischemic injury activated inflammatory, coagulation, and epithelial repair pathways, including kidney injury molecule 1 and interleukin 16, which were unchanged in volume depletion. Interestingly, even different nephron segments responded differently to volume depletion, which affected the inner medulla, while ischemia was primarily in the outer medulla. And different mRNA expressions were seen in these two different conditions. So clearly, while it appears clinically and with markers like serum creatinine that ischemia and volume depletion are a continuum, at a molecular level, it appears that the kidney is affected differently by these two conditions. So based on this, genome-wide association studies looking at different upregulated genes in acute kidney injury can tell us that we have different phenotypes of acute kidney injury with different inflammatory pathways, different coagulation pathways, and different biomarkers being upregulated depending on the etiology or perhaps the response to injury, the response to the damage associated molecular patterns, which may be irrespective of the rise in serum creatinine or urine output. So we need to look at acute kidney injury in terms of phenotypes and genotypes which are different. When we look at etiologies, this is typically what most hospitals and ICUs in India will see. Community-acquired acute kidney injury in India is different with malaria, leptospirosis, snake bites, and other conditions. Whereas when we look at purely hospital-acquired, there is a remarkable similarity to what is seen in the Western world with surgeries, septic shock, drug toxicity, and underlying other diseases playing a role. A particular interest of mine is snake bite, and thrombotic microangiopathy in snake bite resembles the hemolytic uremic syndrome. Russell's viper venom contains the DRKIN1, a heparin-dependent binding inhibitor of activated protein C that produces a coagulopathy in the microcirculation of many organs, including the kidney, a venom-induced consumptive coagulopathy responsible for a very severe form of acute kidney injury. Cobra venom also contains a C3 convertase, which activates the alternative pathway of complement, thereby producing a complement activation injury, which is responsible. And when we look at various series, starting from the one in PGI Chandigarh in 1989 and coming down to JIPMER in 2016, we have seen that there is severe coagulopathy in snakebite injury, and unfortunately, the need for renal replacement therapy can be between 70 to 100%, and mortality has remained in most series distressingly high at 25% or so. This is a very simple look at my own ICU, 1141 patients, a large number of septic shock, but we also get dengue, we also get falciparum malaria, leptospirosis, and other. So the last part, what does one do at the bedside? It's nice to have biomarkers. It's nice to have look at phenotypes, and the time will come in the future when we will be using this information to treat our patients. But for now, what we have is urinalysis, ultrasonography, some indices, and in rare cases, the renal biopsy. This is a spun urine sample, and what we can see here are dysmorphic RBCs marked with the red arrows. This is an isomorphic RBC, which looks normal on a spun sample, and this one, which has these little spikes sticking out from it, is called an echinocyte. It is an RBC which has been squeezed through the glomerular capillaries and appeared in the urine, so it indicates glomerular injury. Another form that indicates glomerular injury are the presence of tubular casts, as seen by these arrows, and the presence of crystals, which is seen here, can indicate either a tumor lysis syndrome or acute phosphate nephropathy, as seen by the white arrowhead. Ultrasonography has been talked about in the assessment of fluid status. It's absolutely invaluable in the assessment of acute kidney injury. Obstruction, as seen in figures A and B, is marked by the presence of a dilated pelvic elation system called hydronephrosis. If this is seen, it's a simple job. Deobstruct the kidney, the acute kidney injury will improve. Figure C shows a highly echogenic kidney. So a patient who has presented for the first time does not have acute kidney injury in this situation, but chronic kidney disease and needs to be treated as such. Figure D shows these echo-reflective calculi throwing an acoustic shadow, and figure E, something that is better picked by the CT scan, but at the bedside, ultrasound can tell us these white shadows marked by arrows both in the pelvic ileal system and in the parenchyma are gas shadows. This indicates emphysematous pyelonephritis, a particularly virulent condition which can produce acute kidney injury. When we are dealing with contrast, we have a simple bedside score to predict the chances of contrast-induced nephropathy known as the Meran score. It includes hypotension, the use of intra-aortic balloon pumps, congestive cardiac failure, age, anemia, diabetes, and the volume of contrast used. And the score can be, the risk score can be low, medium, or high, and it predicts the risk of developing contrast-induced nephropathy and also the risk of needing dialysis. This score has been validated in multiple studies, and we can use it as routinely at the bedside to decide on the relative benefits versus the risk of acute kidney injury in patients to be submitted to IV contrast studies. A renal biopsy, not often required in ICU AKIs, but in rare situations, this is a patient who was not recovering after 10 days in the ICU, and the renal biopsy shows the presence of these fractured casts with a giant cell reaction around them. So this patient had multiple myeloma, which was picked on a renal biopsy, and then we went backwards and found on a bone marrow the presence of myeloma. This is crescentic glomerulonephritis with a fresh fibrin crescent in the glomerulus, seen in vasculitis, antiglomerular basement membrane disease, and others, may be accompanied by pulmonary hemorrhage, which requires very aggressive treatment with steroids, cytotoxic agents, and plasma exchange. This is my favorite condition for acute kidney injury, thrombotic microangiopathies. You can see here these microthrombi in the glomerular capillaries, which are chock full. You have no patent capillary spaces, and also in the accompanying arteriole. So this is a glomerulus, and this is an efferent arteriole completely occupied by a microthrombus, a fresh microthrombus with fibrin in it. It's particularly common in the postpartum period, and this is a study of 52 cases of postpartum acute kidney injury, which we published 2 years ago in the Asia Pacific Journal of Nephrology. 23%, or about 13 of these patients, had postpartum thrombotic microangiopathy. And what we were able to show that was that in Indian women, the postpartum acute kidney injury is frequently caused by hyperactivation of the alternative complement pathway because of a genetic predisposition in the complement regulatory genes. There will be a further complete talk on the acute kidney injury care bundle. So I wouldn't go into the details of it right now. We've heard about the use of crystalloids. We've heard about the recommendations against the use of starch and other colloids. And we've also heard about the vasopressors that will be used. I'll only talk for a minute about the nephrotoxin stewardship, mainly to say that there can be occult nephrotoxins. So glycerol, sucrose, which is the vehicle for IV immunoglobulins, and voriconazole is not an often recognized nephrotoxin because we don't realize it is present when we use these drugs, and it can produce this type of vacuolation of tubular cells, what is called as osmotic nephropathy. So if I had to summarize, the KDIGO definition of acute kidney injury is now universally used despite its limitations, but we need to understand that these limitations exist, that acute kidney injury, that are inability to make a difference after 75 years of having renal replacement therapy to the mortality is because acute kidney injury is not a single disease, but a syndrome with multiple phenotypes. That newer biomarkers are becoming available, but are not yet perhaps ready for big time. There are geographical variations with diseases specific to countries like India, and we can talk more about those. And we need care bundles to avoid, including avoiding nephrotoxins and the occult, especially the occult ones, to prevent and minimize acute kidney injury. Thank you.
Thank you, Dr. Valentine. This is a nice topic as we all face our in ICUs, acute kidney injury every day. Any questions from anyone, sir?
Well, Dr. Lobo, it is again very nice to hear from you, always enchanting. I just have only one, because as the topic was also there, how to assess your patients by the bedside, it was there. So can you just elaborate in 1 minute or 2 minutes exactly?
So
how to assess my patient by the bedside?
So apart from the hemodynamic monitoring, which all of you have covered, what I would do is, as I said, I would always do a urinalysis if I can get a sample. So I would know whether my patient has a tubular disorder, an interstitial disorder, or a glomerular disorder, because glomerular disorders require specific treatment. I would always do an ultrasound to rule out obstruction or to know whether I'm dealing with acute kidney injury or perhaps chronic kidney disease, because there's again a specific treatment that can be offered for obstructive nephropathy. And the indices, there are indices. So I talked about pre-renal azotemia. For many years, the simple method that we used was look at the ratio of blood urea to serum creatinine. If the ratio of blood urea to serum creatinine is more than 40, it's likely to be pre-renal. Knowing, of course, that this also occurs in sepsis, in patients who have received intravenous high-dose steroids, in patients who have a GI blood loss, and in patients who are taking diuretics. In the situation where the urea is low, despite the patient having a low urinary sodium or fractional excretion of sodium, but a low urea to creatinine ratio, this is likely to be a hepatorenal syndrome. So these simple tests, the urine sodium, the ratio of blood urea to serum creatinine, the fractional excretion of sodium may or may not be used, with the caveat that if you have used dopamine, if you have used Lasix, or if you have to some extent used adrenaline, then the fractional excretion of sodium is no longer useful. And if my patient isn't improving either within a period of 3 weeks, or if my patient from day one has features which do not suggest to me that he has what is commonest in the ICU, acute tubular necrosis, then I would stabilize the patient and go for an early renal biopsy. It's available to us at the bedside. We have availability of ultrasound, which has made renal biopsies very safe, because and also improve their yield. So in this small subgroup of patients, and we did publish that study many years ago, patients suspected to have disease other than acute tubular necrosis, we did an early renal biopsy, and we found that in almost 50%, the management was altered. So this is what I would do to assess my patient at the bedside.
Fantastic, Dr. Lobo. That means you are basically highlighting that we should not forget our basics, go for a simple urinary test, maybe a centrifuge of the urine, and tell you many things about the type of the disease that you are having. You're also sticking to the fractional excretions. They're very easy to diagnose by the bedside. If you send the sample of the urine and the blood together. Yes, if the patient is on diuretics, maybe fractional excretion of sodium might be misleading. Maybe that time we check the fractional excretion of urea. And apart from the urea creatine ratio, very easy to do all these things. So very simple things that you are highlighting that we should not forget, and we should continue with that. Another just simple question to you: how do you assess whether the patient will move towards a more severe AKI?
Yes. So one of the things that can be used, I did not, because there is a further talk on point of care.
I know that, but still.
So that's why one of the things that can be used is the furosemide stress test. There is also a marker, the nephro check. The nephro check will be shortly available in India as a bedside test. It will take us about 20 minutes to estimate it on urine. A cutoff value of 0.3 or more than 0.3 will generally be used as a marker of more severe. And it's been recommended that we can improve our sensitivity of diagnosing patients who are likely to move on to more severe AKI and need renal replacement therapy by combining the nephro check with what is known as the furosemide stress test. We give 1 milligram per kilogram of intravenous furosemide to the patient if the patient is diuretic naive. If the patient has received prior diuretics, then 1.5 milligram per kilogram. And I remember it as the rule of 2. At 2 hours, if the patient has 200 ml of urine output, he is diuretic responsive, he's less likely to progress. If the patient has less than 200 ml at 2 hours, he has a higher likelihood of needing renal replacement therapy, maybe at 7 days. So this is another test that can be used simply at the bedside, and a combination of nephro check and the furosemide stress test perhaps improves the sensitivity and specificity.
Excellent, Dr. Lobo. That means furosemide stress test, especially after the patient has been well resuscitated with volume.
Well
resuscitated, you have to go for the furosemide stress test. And maybe if we can combine this nephro check along with furosemide stress test, we might lead to that million-dollar question: exactly when exactly to start our renal replacement therapies in our patients.
Absolutely.
Maybe the classification that is given by Osterman with the biomarker one becomes more enlightened with this type of newer biomarkers and newer assays. Thank you so much, Dr. Lobo. It's really enchanting again to discuss with you. I think the discussion will continue during the conference, and I give it over to Dr. Gurkirat. Dr. Gurkirat, you have to excuse me for the next 2 lectures. And Dr. Vinay and you have to continue. Dr. Lobo, Dr. Gautam, and Dr. Sunil are already there. They're efficient speakers. I can see Dr. Gautam out there, Sunil out there. So thank you, and give me a bit of, I say goodbye to everyone, and I can meet you during the conference. Thank you so much.
Okay,
Thank you.
Thank you, Dr. Lobo and Dr. Chatterjee, for being with us. Now, I would like to invite Dr. Sulin Karan. He is the Chief and HOD in the Consultant Critical Care in Bangalore. He'll be talking about role of CRRT in toxicology. Dr. Karan, please.
Thank you, Dr. Kaur. And it's good to see Dr. Lobo, Dr. Chatterjee, and everyone whom we recently met in the conference as well. So it's always a pleasure to interact with this group of eminent faculty. So I'll be talking about the next 15-20 minutes on the, you can hear me, right? Audio is clear? Yeah, thank you. On the role of CRRT in poisoning. Now, this is a area which is, sorry.
Yes, sir, we can see your first slide.
Yeah, is it okay?
Yes, sir. Yeah, it's coming. Yes, sir.
So setting the context would be that ever since CRRT has been discovered in the mid-70s and early 80s, the utility of CRRT has sort of pushed the frontiers of various other applications to the initial one it was used for. So in this context, toxicology is also one aspect of critical care where CRRT has played a very limited role. I should admit that the extent of work that we have of CRRT in the use of its use in toxicology and in the treatment of xenobiotics or elimination of xenobiotics has been quite limited, largely to poor quality data, case reports, case cohorts, etc. So just a quick recap of the different modalities of CRRT, as we all are probably already gone through: CVVHF, CVVHD, and CVVHDF. Now, it's important to understand that the clearance in certain aspects, especially in dialysis, would be dependent on a variety of factors, and important aspects of this physical aspect is that there is a compartment model which plays a role. There's a role of blood flow as well as what is called the rebound phenomena. Now, the determinants of the rate of solute clearance would be dependent on the blood flow, the inherent property of the membrane itself, protein binding, and volume of distribution. I'm sure the first two is already been discussed in great detail, but this is the aspect which will play a big role. That's the protein binding and volume of distribution of the solutes, which may have to be given certain importance when we decide whether CRRT or what modality of CRRT perhaps is useful in these patients. Two terminologies to understand is, one is clearance, which refers to the virtual volume of blood from which a solute is completely removed during a period of time, means the amount of the solute that's remained in a unit of blood over a period of time. So that's what clearance would mean. And the next important terminology to understand is extraction ratio, which is the percentage removed from the plasma as it passes through the filter and is expressed as the extraction ratio. So extraction ratio is nothing but the concentration in the plasma coming in and going out divided by the plasma which is divided by what is going in, and that can be used to calculate the clearance, which is the extraction ratio, into the plasma flow rate. Now, some molecular properties which determine the pattern of clearance is that ease of clearance is much better with CRRT if the molecular weight of the proposed toxin or the target toxin is of low molecular weight, expectedly because it can pass through the membrane pores, or it is highly water soluble, which can and largely restricted to the extracellular space, because if it's an intracellular toxin or if it is something which enters the intracellular compartment, then there is a certain amount of equilibrium that needs to be established. So it's not only enough if we pull out the extracellular toxin or the extracellular component of the toxin, but the intracellular toxin also gets released over a period of time, causing what is called as the rebound effect. And of course, limited protein bounding. So in short, a low molecular weight, water-soluble, limited protein-bound toxin is easily removed by CRRT, as against a large molecule which has lipophilic properties and has a large volume of distribution, including intracellular toxin component. Now, we are aware of the fact that dialysis is predominantly done by diffusion and hemofiltration by convection. Now, when we talk about certain toxins, there could be other mechanisms or other proposed mechanisms by which these toxins may be removed or these mechanisms may act as adjuvants in the removal of some of these toxins. And these include the synthetic membranes, which can bind to proteins, cytokines, and drugs, and therefore cause what is called as an adsorption of the surface on the on these various surfaces, including on the membrane itself. So to hasten this, or to sort of propagate this, or to accentuate this particular method of elimination, there are certain other additions that are done, which includes hemoperfusion using charcoal hemoperfusion filters, or albumin accentuated CRRT, where these additional molecules or these additional substances are used as adsorbent devices to facilitate this process of removal of some of these larger toxins, which do have the property of adsorption. Now, one fundamental problem that we have with patients who undergo hemodialysis for various molecules, including urea, and also to that extent, some of the xenobiotics, is the post-dialysis rebound. So dialysis generally is a much more effective method of clearance of these substances, because of the fact that there is because clearance is largely based on blood flow and also based on the diffusion gradient. And once the clearance happens, which is quite rapid, depending on a certain amount of blood flow, with the help of dialysis, some of the toxins, especially those which are highly protein bound or do have intracellular components, do get released through these stores over a prolonged period of time immediately after clearance from the extracellular compartment. And this is what we call as the post-dialysis rebound phenomena. Now, this phenomenon is well described with urea. We do see it with other electrolyte imbalances such as hyperkalemia as well, and a number of other sort of toxins which are lipophilic, intracellular, and have a large volume of distribution. So in that context, the pros and cons of CRRT in toxicology is, at least out of some of the theoretical considerations include that the use of CRRT is definitely handy in patients who have unstable hemodynamics, which is not very uncommon in some of these patients who do have xenobiotic overdoses or variety of drug overdoses or toxic or pharmacological overdoses. Most importantly, we also can ensure that this this clearance can happen over a slow period of time, therefore decreasing the risk of what we call as rebound phenomena. And also the use of hemofiltration theoretically does cause help in the clearance of larger molecules through the process of convection. But the major disadvantage is that it is a slow technique, labor intensive, and as I already mentioned, clearance with the help of convection or CRRT is extremely slow because of the slow blood flow and the very slow clearance rate based on the membrane characteristics as well. Now, these are some of the substances which have been used in various sort of anecdotal reports, cohorts, and case studies, wherein they have used CRRT as an experimental tool or as a clinical application or extrapolation from other sort of literature or other experiences that we have had with CRRT. And the common drugs that we look into are toxic alcohols, carbamazepine, metformin, salicylates, theophylline, and valproic acid. I think clinically common would be lithium, carbamazepine, and toxic alcohols, especially in our setup. Now, starting with the first xenobiotic, namely lithium. Lithium generally follows sodium kinetics, and it's a small alkali metal which is having a significant clearance of around 70 to 100 ml per minute when the blood flow is around 200 to 250 ml per minute. Now, this blood flow is often looked at in SLED or hemodialysis, and therefore you do find that there is substantial clearance and much rapid clearance than what a normal kidney would do when hemodialysis is used. Particularly in chronic toxicities or acute and chronic problems, one of the major concerns would be the rebound phenomena that can happen with lithium. So though with the use of hemodialysis, particularly in stable patients, we do achieve rapid clearances. There is a disadvantage of rebound phenomena if there's an acute and chronic problem, and therefore there could be a role for CRRT to decrease the risk of rebound phenomena associated CNS toxicities, which can be a problem in patients who have acute or chronic poisonings with lithium, or those patients who are on chronic lithium therapy and do develop acute increase in the lithium levels due to any reason, could be AKI or a lithium overdose or things like that. In this context, CRRT has played a role, and there is sort of sketchy data to say that, or sketchy experience by various clinicians and authors who have used CRRT in this context with the hemofiltration rate of around, or a replacement rate of around 1.5 to 2 liters to achieve about 50 to 60 ml of clearance. So you see that the clearance rate is about half of what would have happened in the context of hemodialysis, and therefore the rapidity of clearance is much lower. But this slow clearance over a prolonged period of time is useful in clinical settings when we talk about particularly lithium, because of the decreased risk of rebound, which can happen in these patients. Now, overall, if you see, there could be no difference between the two modalities, and it is probably individualizing a therapy for a given patient is appropriate to decide whether CRRT is a better modality or hemodialysis is a better modality for a given patient or in a given clinical scenario. The second aspect of utility of CRRT or RRT in toxicology is methanol and ethylene glycol. Toxic alcohols with a moderate sized molecular weight of around 30 to 60 daltons, dialyzable toxins. So therefore, the role of CRRT is quite limited in this particular context if the patient can tolerate hemodialysis. And as you can see in this table, again, a good amount of clearance can be achieved to the tune of about 200 to 250 ml with conventional hemodialysis blood flows of around 200 to 300 ml per minute. And you find that the CRRT clearance is much, much lower. But they do have a specific role to play in certain scenarios, especially if you find that there is hemodynamic instability, and if the patients actually do present late, or in those patients who do have elevated lactate due to the shock or other sort of causes that can or other reasons for lactate generation in these toxic alcohols. So specifically speaking, CRRT is probably useful in toxic alcohols if there is hemodynamic instability, or if you find that there is significant lactate, which is theoretically better cleared with the help of hemofiltration or replacement or convective methods of dialysis. Carbamazepine, an anti-epileptic, which is highly protein bound, has a molecular weight of about 236 daltons, pretty heavy molecule, high protein binding. So obviously not a very dialysis effective drug. And perhaps the same problem we do face with CVV-HD or CVV-HF because of the fact that it is highly protein bound with a large volume of distribution. Now in this setting, using albumin or charcoal hemoperfusion or any other adsorptive mechanism may be efficacious or may add to further or more rapid clearance of the toxin. Recent use of high flux filters, which are having larger pores and more rapid and achieve more more rapid clearances, can be done with the help of these high flux filters. So the role of charcoal hemoperfusion with the newer generation filters is much, much lower. And this is one place where CVV-HDF may have a role to play if you are finding that the patient is having significant signs of carbamazepine overdose, shock, arrhythmias, probably seizures, and where you want the levels of carbamazepine to actually drop rapidly. Valproic acid, another large molecule drug, heavy molecular weight drug with the significant protein binding and a small volume of distribution. Very limited data on the use of RRT itself, and just some occasional case reports of use of either intermittent dialysis or CRRT. And in both these contexts, depending on the hemodynamic stability, CRRT may play a role. One important thing that has been noted in some of the case studies here is that the rebound phenomena seems to be high with valproic acid, even in the presence of, or even with the use of CRRT, possibly because of the significant high protein binding that we do see with this subset of patients, or when those patients who have overdose of valproic acid. And this leads to the fact that even if you're using CRRT, it is very likely that you will need very, very long periods of CRRT. So it's not unusual for those patients who have high levels of valproate or who have acute injections of valproate to undergo CRRT for about 3 to 5 days on a trot to achieve reasonably therapeutic levels, or to drop the valproic acid levels to more reasonable or safe serum levels. Theophylline, again, sort of a molecular weight of 180, moderate volume of distribution, not so very protein bound, about 50-60%. Actually has good clearance even endogenously, many times does not need additional support, but when used, charcoal hemoperfusion adds significantly to the clearance, and CRRT may have a role to play. Data does show that there is substantial reduction in the half-life from days to hours when we talk about using CRRT, but whether it is often indicated, the use of RRT itself is generally not very necessitated in theophylline, unless you find that the patient has substantial ingestion and there is cardiovascular collapse. Metformin, as you all know, has the problem of not only the toxicity, but also has a substantial risk of AKI and causing lactate sort of induced metabolic acidosis because of its enzymatic action on the intracellular cell oxidation mechanism. So it's a highly soluble, water-soluble drug with minimal protein binding. And there seems to be a good efficacious clearance with the use of both dialysis and CRRT. Here, many times, hemodialysis often suffices, but if there is significant hemodynamic instability because of the acidosis, then it is only then that CRRT may have a role to play. But in this particular medication, the role of CRRT is extremely limited, except for the fact that when the patient is in shock. Salicylate, good experience with hemodialysis, very limited data for the use of CVV, H or CRRT. Its only role may be when the patient presents very late and when they are extremely unstable hemodynamically as well. The other poisons or other indications where CRRT has been tried in different clinical contexts are with rat poison, organophosphate, medications like iodine, methotrexate, vancomycin, which are all sort of protein-bound drugs, procainamide, and of course paraquat. Now, one of the issues here is that the major indication of use of CRRT in this setting is only when you have substantial hemodynamic instability, and these patients cannot be dialyzed, where conventional dialysis is often difficult. Off late, plasmapheresis or high volume plasmapheresis is actually replacing CRRT as a modality of extracorporeal elimination of extracorporeal method of eliminating these medications, particularly in the context of hepatotoxic drugs like rat poison. So in short, CRRT has a role to play, very, very selectively in specific circumstances when we talk about those patients or those drugs which are wherein there is a risk of rebound phenomena, or the patients have severe hemodynamic instability, slow clearance, and where you are actually looking for slower clearance. In fact, I would even go to the extent of saying that in those patients where there is a risk of rebound phenomena, or on those medications or drugs where there is a risk of rebound phenomena, there is probably doing a repeat dialysis in about a matter of 6 to 12 hours will serve the same role that CRRT would do. So the role of CRRT would be very, very limited in these poisons or in toxicology for those patients where dialysis is not practically feasible because of severe hemodynamic instability, which seems to be the only most accepted indication at this point of time. Thank you.
Thank you, Dr. Sunil, for enlightening us with the toxicology and CRRT. As we all get to see so many cases in Punjab related to toxins like organophosphates and rat poison and cell-phos. So it helps before, like if the patient is not very unstable and prior to ECMO, we can always try this. Any questions from anyone? Dr. Vinay, Dr. Gautam, please.
Excellent, Dr. Sunil. Nice presentation. And again, have you seen any these paraquat and all of late in your practice? Yeah. And have you done any experience of other hemoperfusion techniques or CRRT for the same?
So hemoperfusion, especially, it's very hard to get these filters these days, the charcoal hemoperfusion filters. So many times, if it is a drug like carbamazepine, we either use conventional CRRT or a high flux filter, where we can actually do a HDF or even a SLED with a very short period of time. We actually do get significant amount of clearance. Albumin sort of supported hemodialysis can also play a role, but it turns out to be extremely expensive. Paraquat, yes. In fact, recently we have used this thing, but it is more trending towards using more and more plasmapheresis these days rather than CRRT alone. So the only indication maybe if the patient has acidosis, shock, it is probably, and the patient is unstable for a SLED or HDs, when we actually look at CRRT as an option.
Thank you. Thanks.
Thank you, Dr. Sunil. Yes, sir. Now I would like to invite Dr. P.L. Gautam, our own dynamic professor and head of critical care at DMCH. He would be speaking on care bundle in AKI and strategy to prevent AKI in ICU.
Good evening, Margaret.
Good evening, sir.
Bear with me, my voice is little heavy today.
Sir, it is audible, sir.
It's audible.
हम सबका यही हाल है, sir. हम सबका यही हाल है. Please go ahead.
Everyone is going through this viral, sir. Everyone is.
Yes. So I'm going to speak. The topic is easy. That I'm going to speak mainly the attitude. I would say the content. Actually, all three speakers has nicely covered AKI, CRT, and the role of markers. So let me share my slides. Visible? So my talk is on care bundle in AI strategies to prevent AKI. Actually, I will be covering in 3 parts. The first part I must say is what is AKI bundle. So we have used bundles for multiple therapies, like web bundle or centerline bundles. Then what are the benefits and the caveats in this? And what are the challenges and hurdles to implement it, like improving the compliance or the with the bundles also. And we can always say the early recognition AKI is very important. The question is, what is early? So as per the IH, it is defined as a method of improving process of care and the patient outcome with a set of evidence-based practices, maybe 3 to 5 practices, which can join together by gaining much of a benefit. So it's like identifying the patients with the AKI and AKI, like then substituting with the nephrotoxic drugs, looking at the patient's chart daily and the patient also, then finding out what we can do so that we can prevent AKI or we can reduce the severity of AKI. That's what the AKI bundle is there. So as far as when we say to avoid AKI, most of the bundles are focused on once the AKI happens, only then. So avoiding means the risk factors. The risk factors, we can avoid the AKI also. That means that we have to identify the risk also. Progression of AKI definitely, because the more the severe the injury is, the more is the negative outcome. So why it's so important is AKI is multiple reasons are there. One thing is AKI is very common in ICU, almost 50% of patients. And once patient has the AKI, it may progress to CKD later on, or there is accelerated progression to end-stage kidney disease also. And it may result in mortality by number of ways. One is the patient becomes immunocompromised and very prone to infections. Episode of AKI as such is very costly. It leads to more stay in ICU, more investigations, more monitoring, and even support on RRT and multiple things, and makes the patients so financially toxic also. And some of the facts are that we have already discussed, I think need not to emphasize more, that AKI is maybe a reason going up to the level of 50% in ICU patients. And severe AKI, especially with the mortality and or multiple organ failure syndrome, that's very high. And if patient requires RRT, renal replacement, one or other reasons, who are not actually having AKI because of the disease process, it leads to AKI, like patient having trauma or patient having poisonings or patient of infections. Plus, the patient are so sick, their mortality is very high. And one of the contributory factor is the AKI also to these things. And so one of the very 2015 one has a study that the multinational epidemiological AKI study that highlighted the case with short-term mortality in a severely dependent manner. Higher the stage, higher is the odds ratio. That's very important. So if we can stop the progression from stage 1 to stage 3 also, we gain a lot to prevent the mortality. So if there are multiple different hospitals that have designed different AKI bundle, there is nothing like a universal bundle, I would say. So one is like monitor the kidney functions. That is a standard common practice, that monitor urine output and serum creatinine daily. So that is very easy. And check the fluid balance. That's a common thing we can do easily. If the urine output is falling down, that patient is progressing towards AKI. But there are caveats into this also. And checking the creatinine levels also. But they are found with the creatinine level also. Like some patients are so monasmic or sarcopenic, the creatinine may not rise the way it should go with the other patients. And similarly, the daily assessment of appropriate adjustment drugs. If the drugs are there, like antibiotics are there, some of the nephrotoxic drugs are there. Sometimes the nephrotoxic drugs are very important. Despite having the nephrotoxicity, they may be required and may rather lead to improvement in the patient. Especially like antibiotics or colistin is there. Sometimes it's required for it is the only patient is sensitive to colistin. We may have to use it. And similarly, the use of balanced crystalline solutions also. That's also a bit questionable. Whether it's industry driven or there are the studies, cohorts, that, but definitely if the starch is there, it's a detrimental. Then discontinue extraneous potassium supplementation, because if the patient develops AKI, then giving anything which leads to potassium rise, that's not safe. Now, problem with the AKI care bundle is so that proposed AKI too encompassing all the things and too comprehensive, and there are something hidden in between the things in the lines also, which we may miss it. So just looking at AKI bundle, if we put a chart on the file and 1, 2, 3, and this may not solve the problem. There will be much more. It's a tip of the iceberg only. So bundles I picked up like from the different hospitals, the NHS and other things. One is the fluid balance. If we go with any bundle, the most important is the fluid balance. If the fluid is less, that's detrimental. If patient is administered over fluid, because kidney is an encapsulated organ, if the edema to the kidney is there because of overhydration, that's also detrimental. If the low blood pressure is there, or low cardiac index is there, that again is very detrimental to kidney. Then urine output, we can see easily, especially the urine microscopy, which gives a lot of information, which we have just learned that CAS and the proteins, if they are there, we can step up to the next step to see the kidney with the ultrasonography, that is imaging. And imaging can pick up the kidney as such also, how much corticomedullary differentiation is there, whether the patient is having more of a cortical injury or tubular injury. Some of the ultrasonologists may make the comments on these things. Or if there is any ureteric obstruction post-op, or there is something collections, some pyogenic things coming up, we can pick up very early, and the dealing of these things helps a lot in early improvement of that. Then picking up the drugs, all the chart list. If there is any medication which is harming the patient, we can reduce it. Like typically the NSAIDs are very common prescribed drugs. I would say here the more important is NSAIDs may not be detrimental to some patients, but some patients are very prone to getting the injury with the single. Like that is a racial something like patients with the black races, they get very early injury. So depending on those things, which is missing in all the AKI bundle is what our patient is. Then sepsis is one part. Then if the patient is suspected to have, when to give the consultation to nephrologist so that we can take their help and improve the patient or more investigate the patient for other reasons which are leading to injury. I would like to discuss this NHS bundle, which is quite simplified and is encompassing a number of things. The first part is to differentiate whether it's a pre-renal, renal, or post-renal. Looking at, and then patient's assessment, like patient's resuscitation part, that's the first part they see. And check by signs of sepsis daily. If the SOFA score is increasing, that probably it's a sepsis. If you hit the early, the sepsis mortality goes discernibly down, and the AKI also goes discernibly down. Help patient the full bladder. And if there is a looking at that, there is a sign of any injury, like stage going to 3 AKI, urine output is too low, then investigation the early with the help of the nephrologist also. Then there are, ABG is also very important. If a patient is, what is pH, what is happening to the potassium, what is happening to the chloride levels, all the CRP is going. So if we can see these things and address early, the chances of having catastrophic complication, which are vicious cycle leading to more further AKI. Means if the patient, we can pick up patient is going into shock. If we shock, pick up the shock early, or there is electrolyte imbalance like potassium is high or the pH is low, we know suddenly initially patient will have a compensatory mechanism. Later on, patient may not be able to compensate. Suddenly the patient will go into arrest. Once the patient goes into arrest or patient goes into hypotension, then even if we resuscitate, but there will be some damage. So picking up the risk factors, picking up early is very important. We can assess the fluid charts. We can use ultrasound these days are very easily available. We can use ultrasound also because ultrasound multi-ways it's helpful. If the kidney is congesting because of CCF also, we may pick up with this. If the patient is having hypovolemia, and we can these days monitor the renal resistive index also. It's just using stretching the boundaries in ICU of ultrasonography, which may be helpful because one parameter may not give you the information. But if you are looking at multiple parameters, we may pick up the things early. That's the reason the AKI bundle has also come, because assessing with the different parameters and then interpretation of these all parameters in one line that may help you to design the benefit to the patient. So we can go with the ultrasound is available. We can see the bladder scan. We can do the renal tract ultrasound. We can review the medications. Overall, if we can see whether patient is on NSAIDs, ACE inhibitors, ARBs, or whether patient's GFR is going down, we can withhold some of the drugs like metformin is there, or even if the patient is a modification of the antibiotics required, it should be done at the same time. Now, concern in these things, one is the concern is the implementing the bundles. It's the fluid optimization. We have those concept, we can use that, but if we are ultrasound or other tools, we should try to use that. Then there are new modalities, all in the pipeline. So far, they are not user-friendly, reliable, and validated and economical markers. But once probably they will be coming, already they are in the market coming up. So we may in the pipeline down the time, maybe in a year or 2 years or 4 years, we will get these markers where we may pick up the injuries very early. Then is the Nexus tool. What is that? Is venous ultrasonography of looking at the patient's congestive, because most of the patient, once they are resuscitated, it has been found, especially if it's a gain, body gain is 5 to 10%. There is not much of damage, but if it is more than 20%, definitely the AKI is going to come. If it is more than 40% in patients, whether it's a trauma or septic patients, lot of capillary leakage there, kidney being encapsulated, even patient may go into compartment syndrome from the abdomen. We have seen in dengue shock syndromes, we have seen in the patients with the trauma that sometimes the patient requires so much fluid, patient may get the blood pressure, but ultimately patient may lose because of there is a ischemic because of more over-resuscitation also. Then taking out those fluids is also important. And renal adjustive index monitoring is another part which is coming up that we can see, that is, we can titrate the inotropes also. Like looking at just blood pressure, we can see the cardiac index. Now, we also, there are a couple of problems with the bundle is GFR and creatinine never go side by side. It starts rising only once the GFR has gone to sunny down. But if we can pick up those hypoperfusion early, there are a couple of monitors which are coming in the pipeline. That is a microcirculation picking up. Maybe again, so far it's experimental. That mucosa you can see and see how much microcirculation is affected. Because most of the times when patient starts decreasing the urine output, because the mechanism of body is such compensatory, kidney and heart and the important organs are protected. But most of the starts from the selective circulation, the ischemia or the skin. So if we can pick up those early, we may delay, we may pick up the things preventing AKI early. And urine output also, like in patients, sometimes we are looking at the urine output. And urine output, because of patient, sometimes in the surgery these days, we recommend that don't go with the urine output. Rather than, because if you are giving the kidney, the IV fluids in the perioperative period, kidney is not tuned for, as far as nature, it's not tuned for the IV fluids. It's not tuned for the oral fluids. So looking at the urine output and giving fluids is not a good payoff for handling the perioperative patients. Sometimes inotropes may be better rather than giving the just, because they are body hormones like ADH, aldosterone, because of stress they are coming up, they will reduce the output. Rather than giving fluid to match the output, it's important to see the patient's vascular status, volume status, which we can use the different techniques. So, there are a couple of things people have seen, like providing education to uniformly apply an AKI was not beneficial. So, these are the latest paper, although looking at it more like the river manual's sepsis only, that if we are monitoring the venous saturation, it may not only go direct to therapy. It may not. But the question is, if we are looking at overall AKI, which in this paper also, it has not reduced the mortality. But if you see the RRT, the progression, there was some benefit. So, and it was not a minimal benefit, it was quite significant benefit. So, we may not be able to, prevent AKI, but definitely progression of AKI can be stopped. It's more important is to see the paper in detail. Even if you see this cohort in this Fennec study, which was one of the Finland. They said the AKI is not the independent risk factor. That's true that overall disease is the culprit. It may not be an independent risk factor, but if you compare both the data with the matched and non-matched, there is a definitely AKI. If it's there, it leads to more mortality. It's a risk factor. It may not get the statistical significance, but the translating into these concepts to achieve the maximum is another part. One is early recognition. The question is how early is early. If a GFR is already gone to 60, 70 when the creatinine starts rising, so we should act at that time. You don't know today's last poll, the organs are being affected by the hypovolemia. Similarly, there are markers are there, novel markers are there, maybe the answer to these things, or maybe the risk factor we should look at rather than only the AKI once it starts happening. Another thing is early management using advanced tools, using ultrasound, avoiding nephrotoxic drugs at all. That may be. And if hitting the pre-renal component, maybe the answer to many of the questions we are discussing. And benefit of AKI care bundle, there is a couple of studies which are going quite favor the compliance with AKI. The care bundle was as well the decrease in case fatality as well reduced progression to higher AKI. So looking at the overall data, there is a benefit, and their meta-analysis also favoring that. If we are looking at, I won't be going into the definition and diagnosis, we have already discussed, but the only thing is there are lacunae in the all definitions. And if we can pick up the things early, and the important thing to understand is the pathogenesis, which is very simple, is if the stress cell is it's recoverable. Cell injuries, there will be some damage, but you don't let the patient to go to the irreversible stage. That's a very important part in understanding the pathogenesis. Sorry. We see the pathogenesis is very complex. There are damage-associated patterns and pathogen-associated molecular patterns. So complex, each and every body is different. His response to host response to immune system is different. That we have seen the COVID also. Some patients get COVID severe, some they are just having mild. And similarly, some patient may not get AKI with the same sort of insult. The other patient may have an exaggerated response. And there are intrinsic as well as extrinsic factors. Some of these factors we can't do anything, and some of the factors we can modify. Like patient having these afferent arterial vasoconstrictors, like hepatorenal syndrome is there, sepsis is there, hyperglycemia, congestive cardiovascular. That is an intrinsic afferent arterial vasoconstriction, which is compensatory. Chlorix is there, patient is having already hypertensive or kidney disease. Mechanism, patients already, we can't change overnight the patient's atherosclerosis, hypertension or diabetic nephropathy. These patients have another problem is they may not respond in the same way to the insult the normal patient they respond. Extrinsic factors which we can easily modify is like patient we are giving the contrast, or patient we are giving immunosuppression, or we are giving patients anti-inflammatory drugs, or we are giving patient AC inhibitors or ARB drugs. So these are the couple of things, the antibiotics also, which we can alter if required, only giving it. So ultimately, it's the reduced GFR or accumulation of urea creatinine which we can pick up. Most of the problem is these parameters are not differentiated between the pre-renal, renal, post-renal. If we can differentiate between the pre-renal and renal, whether it's the markers or it is looking at the patient's ultrasonography or patient's fractional acceleration, I'll come later on these things, although we have already discussed these things, that may be the very helpful. So once we are going with the bundle, another thing is the management. If the patient is getting life-threatening features like hypotension shock, address it immediately. Hyperkalemia is another, and treat the underlying cause. That may help it. But if patient is requiring renal replacement, and there are a number of reasons in ICU which patient may require renal replacement, don't delay it. It's better to do it early, because once the patient comes unstable too much, it will be difficult to institute the therapies also. Like if the patient goes into hypotension, it will be difficult to start the RRT. Then the right time for the right choice is important. That severe refractory hyperkalemia is coming up. It's better to address at the same time. Fluid overload is there. We can use ultrasonography. We can use severe stenosis there, drug overdose, which is diarrheal. Then we should do it early. Looking at it's just a clinical sense also, more than the investigation. If the patient is hypokalemic, dehydration, shock is there, patient is looking at hepatorenal syndrome, or if your patient is on devices like ECMO devices or intra balloon pump, where the patient's cannulas are there, there are small things that make a huge difference. And if patient is on ATN is there, which is very common with the patient is having TTS, TTP or HUS or patient having pancreatitis. There are a couple of things where even the CRT or the plasmapheresis may be very helpful preventing these conditions. In patient with a history of CKD, compromised autoregulatory mechanism may boost the GFR. So that's another thing. If patient is having underlying CKD, or there is evidence of on the ultrasonography, or patient is a known case, we should be more careful. But these are the patients where the small insult is going to be a very major insult. We can use differentially pre-renal and renal, because pre-renal is easier to address than the renal, because once the renal is there, less patient will require RRT. But if the pre-renal is there, patient may be responsible to fluid therapy. Like that is, we can use fractional concentration of sodium. If a patient is not given diuretic, or we can see the proteinuria or sediment analysis, if the hyaline caster is there, or we can use the urea protein creatinine ratio also. We can look at the sodium, urinary sodium potassium ratios also. And then we can see the osmolarity and these things also. So we can pick up these things early and can handle these things. But overall, ATN is the most common renal secondary to nephrotoxin insult, whether it is a prolonged ischemia. Once it's established, the answer is an renal placement therapy. There are other reasons in the renal, that's vascular or interstitial. Interstitial drug-induced is also very not uncommon. If the patient having eosinophiliuria or there is urine output is maintained in this patient, mostly it's the patient's creatinine level is going up. So it's interstitial, stopping that drug may be helpful. And sometimes the patient is having a rheumatological disease like lupus, Wagner's or Goodpasture syndrome. Patient may be in a flare-up of exacerbation of the disease. If those are the patients where we find these things, pulmonary syndrome, cardiorenal syndrome, or pulmonary hepatorenal syndrome. These are patients where the approach is going to be different, and addressing individual disease, with whether it's with the steroid or plasmapheresis, may be very helpful. So identifying the patients at risk, one is most important is the clinical parameters, then is the markers. So now using the ultrasound in ICU, along with the sepsis identification, may help a lot in preventing AKI, because sepsis is also very common cause of AKI in ICU. We can clinical vigilance is one. Another is the SOFA score. There is an investigation alert. If the trending in the creatinine or the urine output, it's going towards that. Even if there is not a 0.3 rise, daily the TLC is going up. Those are always a thing of concern. Looking at cumulative balance or Wechsler score. Now the Wechsler score is, I'll just in the next slide, I'll tell you what is the Wechsler score. And again, I want to emphasize on this is the urinary routine examination is very important. And we can do that. We should see these things also. Then is the ultrasonography, looking at renal as well as a bladder scan. Then review the medication, stop the harmful drugs, check for the dose adjustments. If the NSAIDs, it's very common in our ICU also, we have looking at the patient is on non-steroid NSAIDs very commonly, and these things should be avoided. The thing is anticoagulation, okay, like patient or anticoagulation or antidaptic drugs, patient may get insult because of the patient's GFR is down. So fluid status, multiple ways, and reliability and validity of assessment is always a question. There are a lot of gray areas in monitoring this. Dynamic parameters will always say PVV, snowfalling variation, VTI, PR are all are important, but may not be alone the answer. What is the Vexel score or blue protocol that is very important in looking at the patient is hypovolemia. One is a hypovolemia which we can see. Another is hypovolemia which is most of it's iatrogenic. Looking at the IVC, which is called the Playboy sign, and just distal to the hepatic vein, that's the area we see. If patient's IVC is more than 1 meter, it's more important to see the hepatic veins. And if hepatic veins are showing the reversal, then we should start looking at the patients. Going further, there's a portal vein. If the portal vein is also showing the depression of the systolic flow, then it's important to see the renal vessels also, how much fluctuation is there. So in that score, we can just avoid the congestion or over resuscitation in these. But all middle components are not equal. Hypertension and low cardiac index is individually and the risk factor important. Thing is the use of contrast and nephrotoxic drugs. There's another part we should see very often. That's very important. And hemodynamic status is when seen that if patients whose cardiac mean arterial pressure was low or patients cardiac index was low, they have much more progression of AKI. And when to get the nephro consultation, not all patients we can ask for the consultation, because if he starts asking 50% patient having AKI to look at that may not be feasible, that may dilute the power. So it's more important is a patient with a stage 3 AKI, refractory hyperemia, pulmonedema, refractory metabolic stenosis. Either we can start with the CRT or the renal placement ourselves, or we can get their help. So other consultations sometimes important, like in pregnant patient, pregnancy may be important, then obstetrical consultations. Sometimes the patient with coming with the TTS or hemolytic uremic syndromes, there may be the consultation with the hemo-oncology or with the urology sometimes, even sometimes with the rheumatology people is very helpful in preventing these AKI. And specific population, massive fluid resuscitation, it may be a compartment syndrome, looking at the urine, although this may not be covered up exactly in the bundle, but that's important because it's a life-saving sometimes, just decompressing the abdomen. Rhabdomyolysis is there, patient may not show signs much. Patients, if there is alteration, the urine water color is different. Before the patient lands up with the AKI, it's better to take out the myoglobins in these patients. So we have a couple of charts looking at the acute kidney injury. Some of them are clinical, whether it's markers or it's looking at the patient's susceptibility, that if the patient is CKD, hypertensive or diabetic, we should look at these patients. They are very prone. Then looking at patients' urine output is another. Then looking at the trajectory. If the patient's urine output has gone significantly down, that's a time to address because it will affect the outcome. But very important is looking at the subclinical marker, which is possible only looking at the patient very closely, looking at patient's ischemia, nephrotoxic drugs, sepsis. So if we can address the subclinical, patient will not go to the clinical. So improving compliance for the AKI bundle is late to recognize or ignore early warning signs is always a problem. So the answer is conscious checking and adding the checklist. That's the one way. What is the conscious checking is because we have a habit of lapses of memory. So errors are common. So conscious checking at the patient and patient's chart, that's one thing. And then looking at patient's fluid balance and diagnostic for these things and medication adjustment. I think. Thank you for your attention. I can take questions if any.
Thank you, sir. Any questions from anyone? Okay, I think everyone has understood or didn't understand anything. So next, if there are no questions, we would like to move on with Dr. Suman Sethi. She's an associate professor in our own hospital, DMCH. She'll be talking about point of care testing in critical care nephrology, present and future. Suman ma'am, welcome ma'am.
Good evening, everyone. So today we will discuss a very important topic, the point of care in the critical care nephrology. So let me share my screen. The screen is visible.
Full screen is
Yes.
not there, Dr. Suman.
Ma'am, it's visible.
Right.
The small, yes, ma'am, it's visible. You can just move the slide so that we can see it moving.
So today we will discuss about the point of care testing in the critical care nephrology, which is very important and the hot topic in the today's time. So the point of care, that is POC testing, is a diagnostic testing. This is performed outside of a central laboratory at the site of the patient care, such as it can be done in a hospital, in emergency room, or a physician office, or at the home. Now, the primary advantage of the POC test is its ability to provide the test results rapidly, so we can facilitate the earlier treatment in these patients. Now, other advantages include the avoidance of the specimen processing and the smaller volumes of the specimen needed for the testing. So, although the POC testing is a relatively new paradigm in the laboratory analysis, nephrologists have been familiar with this concept for the several decades because they are doing the dipstick for urine analysis for a quite long time, which is routinely performed in the office setting and even at the home, which is a type of the POC testing. Now, in center, point of care testing is frequently utilized across the multiple specialties now. So, WHO assured to make a criteria for the evaluating the POC devices. These should be affordable, sensitive, specific. These devices should be user-friendly, rapid. They should be equipment-free, and they should be deliverable to the end users. So these are the WHO criteria for the POC devices in all the fields. So first of all, we will discuss about the very important topic that a POCUS, that is a point of care ultrasound in the practice of the nephrology. So advances in the portability and the affordability of the equipment lead to the rapidly converting sonography into a point of care procedure in performing the clinician. Now, with the application across the entire spectrum of the clinical nephrology, the sonography offers substantial benefits for the nephrologist and their along with their partners. And so advantages of the POC of care ultrasound, the sonography of the kidney is a very integral part for the evaluation of the kidney disease in the ward and even in the emergency. Now, bedside assessment of the intravascular volume status can inform and expedite our therapeutic decisions in these patients and even in the clinical practice and ICU settings. Now, fragmentation of the care is minimized in these patients. Our efficiency is increased and the patient convenience and care are maximized with the use of this POCUS ultrasound. If in sonography in the AKI, if the urinary obstruction is suspected, suppose we are considering the hydronephrosis, then the ultrasound may help in localization of the obstruction to the kidney, bladder, or in between. So we can take a decision. If there is a small echogenic kidney we see on the bedside, it means they need the further workup and it shows the long-standing damage. But the enlarged echogenic kidney may indicate some type of glomerulonephritis or the ATN in this patient. So this is a very important tree demonstrating how the POCUS can be used in the patients with the AKI. So suppose a patient is coming in the emergency and it is a new AKI, means there is a rise in serum creatinine 0.3 milligram per deciliter above the baseline, or the urine output is less than 0.5 ml per kg per hour for 6 hours. Then the first is very important to take the history, do the physical examination, followed by the renal POCUS. Now suppose we are very confident that the hydronephrosis is not present, then we need the further workup for the pre-renal and the intrarenal causes. Now, if we are very confident that the hydronephrosis is present, we can do the Foley's catheterization. We can take the urological opinion or the intervention we can do. And suppose there is a very difficulty in obtaining the images, then we can consider the formal renal ultrasound. So this is a visual representation of the kidney in the POCUS. We can see here the renal capsule, renal cortex, medulla, calyces, and the pelvis, how beautifully they can be seen. And in the hydronephrosis, Suppose there is a mild hydronephrosis, we can see dilatation of the renal pelvis along with the calyces in the picture number 2. In the moderate hydronephrosis, we can see there is the flattening of the medullary pyramids along with the clubbing of the calyces. And in the severe hydronephrosis, we can see in the last picture, there is the loss of corticomedullary differentiation along with the thinning of the cortex. So we can use this example to understand the importance of focus in our emergency and even in the ICU. So this is an example of a 37-year-old male who presented with the history of quadriplegia and the chronic hypoxic respiratory failure requiring the mechanical ventilation by tracheostomy. He was admitted in our ICU with a serum creatinine of 1.39 at the baseline, and the chest imaging result was suggestive of multifocal pneumonia. Later on, he progressed to the ARDS with the septic shock over the next few days. So he requires the inotropic support and the worsening oxygen requirement. So a bolus of IV fluid was administered to this patient, and the nephrology consultation was requested from us for the further input on the AKI. So there is a question was posed about the possibilities of any pulmonary renal syndrome or the glomerulonephritis because the ANA was +1 in this patient. However, bronchoscopy was equivocal for the alveolar hemorrhage. So what we did, now in this patient, he was on mechanical ventilator with the FiO2 of 70% and the PEEP of 12 centimeter. Blood pressure was 96/53 on inotropes and the oxygen saturation was 90%. On examination, there is a pitting edema and the bilateral lung crackles were present, and the urine output was only 350 in the past 24 hours. We did the urine microscopy, which showed the muddy brown cast, means there is a tubular injury. There is no dysmorphic RBC, means there is no evidence of any glomerulonephritis. Further investigations reveal there is a presence of hypernatremia, hyperkalemia, and the serum bicarbonate 25 millimole per liter. So from this presentation with the low fractional excretion of urea, we found that this patient has some signs of dehydration and the intravascular volume depletion. So common approach in this patient is to administer fluid. So what we did the POCUS, means the bedside ultrasound was performed in this patient. So these are the findings of the POCUS in this patient. So first, the lung ultrasound revealed bilateral diffuse B-line pattern with the irregular pleural line consistent with the known ARDS. The focus cardiac ultrasound was done on the bedside, which revealed hyperdynamic left ventricular systolic function and the enlarged right ventricle. And there is the intraventricular septal flattening was noted, which was making the left ventricle look like D instead of the normal shape. So it suggests the patient has volume or the pressure overload. And this can contribute to the decreased cardiac output by compromising the left ventricular outflow in this patient. Now, IVC was also plethoric in this patient, showing the high right atrial pressure. And next, what we did the hepatic and the portal vein Doppler was performed on the bedside, which shows the venous congestion. So finally, it means the POCUS findings are indicating that this patient was severely elevated in extravascular lung water. He has right ventricular enlargement and severe systemic venous congestion. So based on his clinical laboratory and the imaging data, the patient was started on the CRRT to facilitate the fluid removal and aid the renal recovery by addressing ongoing hemodynamic insult. Meantime, we got all the investigation which were found to be negative, including the dsDNA, ANCA profile, and anti-GVM. So renal biopsy was not done in this patient. So on the day 3 of the CRRT, we achieved the fluid negative balance of 3.6 liter. On the day 5, it was 5.1 liter. And slowly we are able to taper off the inotropes in this patient. So at this point, the decision was taken to discontinue the CRRT and plan to transition to the intermittent hemodialysis. On the day 8, the fluid balance was negative 2 liter compared with the day 5. So when we again did the POCUS in this patient, the hepatic vein Doppler normalized with the S wave more than D pattern. Also, the portal vein remained normal, suggestive of resolved venous congestion in this patient. Now, the lung ultrasound also we did the lung ultrasound, which showed the improvement through the findings of increased lung water did not resolve completely. But interestingly, the D sign on the cardiac ultrasound displayed with the return of left ventricle to its normal circular shape. So we can see from this example that how beautifully we are thinking that this patient has the fluid deficit. Initially, we are giving the fluid, but with the use of focus, we are able to manage this patient. We are able to decrease their inotropic sport. We are able to do the CRT and remove the fluid, and how beautifully this patient improved. So what are the limitations of the focus? Now, this is a lack of training. This is the additional cost involvement. And in the high overload patient, where the patient load is very high, this is an additional burden for the physician also, because it took a couple of extra minutes. So after the focus, we have other few available technologies. We can use these technologies at home. First, in the nephrology, very important is always the urine analysis. So the urine analysis can be used in the variety of conditions, such as for the detection of UTI, especially in the renal transplant patient, for the screening of albuminuria in the pregnant patient, hypertensive patient, and diabetic patient. Now, the measurement of both proteinuria and the albumin-creatinine ratio is available, with the validation study demonstrating excellent correlation to the traditional method. So the technology is very easy to use, and the majority of patients prefer the smartphone-enabled approach. So this is a very beautiful picture which showing us how we can use the smartphone, and we can see the amount of urine protein creatinine ratio or albuminuria with the help of the card. Next is the poke microsampling can be done at the home, especially in the renal transplant patient. So as we know, in the renal transplant patient, it is very important to measure the tacrolimus level to adjust their dose. So this tacrolimus microsampling is now available, which can calculate the TAC level at a very convenient method. So this is particularly relevant for assessing the adherence to the immunosuppressive medication in these patients, where the current standard of care only captures the adherence before the planned visit. So there is sometimes erroneous timing of the traditional phlebotomy, which can lead to the non-trough results. So microsampling techniques are available, especially the MITRA devices available now, which enable patients to do a fingerprint capillary blood test at home, which is now well developed and beginning to enter the routine clinical practice. So in this method, the blood sample is aspirated using the capillary action onto a microsampling tip that absorbs a fixed amount of blood and can be posted to the laboratory. So from this, we can calculate the exact level of the tacrolimus trough level, and we can adjust the dose of tacrolimus in these patients. So this is a new study that is published in the Kidney International in 2009. This is the RENA-STIC. Now this is RENA-STIC, which we use to see the various markers for the acute kidney injury. But this RENA-STIC is not very popular. It has quite a lot of advantages and disadvantages. Now advantage is this is a very portable stick. It requires only very small sample volume. Ease of use is there, and it is ability to rule out the injury in the preclinical setting. But there are a lot of disadvantages there for the RENA-STIC. There is clinically focused operator is needed. There is some regulatory compliances is there, problems related to the urine volume, and there is an inadequate quality control and the documentation for this stick. So this stick is still not very popular. Now for the nephrologist, this is very important in the CKD patient to assess the anemia. And anemia management is very important because every patient needs the iron supplementation as well as the erythropoietin. So enabling this care to take place in the home is attractive to the physician and both for the patient also. So there is a new method, LumaStick is there. This is a very small device, weight of 96 grams, which has a mark for home use in the measurement of HP. Now the device mainly uses the microcentrifuge on 4 to 8 microliter capillary blood in a region-free cuvette for the measurement of hematocrit, followed by the photometric absorptiometry to calculate the HB. Now we can use the smartphone app in this patient, which can store their data storage, symptom tracking can be done, and reminders are given into this patient, and there is the display and transmission of the HB result is there. So patient can monitor their HP level at the home. Next is very important is the management of the hypertension, because all we know the good blood pressure control is very important. to slow down the renal decline. So what we know is that ambulatory blood pressure monitoring is there for the diagnosis of the blood pressure. And the principal advantage of AVPM is multiple reading, especially at night, is there. And the main reason why this is not very popular, because they are very uncomfortable and it disturbs the patient's sleep. So now there is a smartwatches are available. So there is a wristwatch called as the BPRO, which is the Health Stats International, using the modified applanation tonometry to require arterial radial pulse wave, and it can calculate the BP in this patient. And this BP mainly correlate well with the upper arm BP measurement. So it is relatively bit expensive watch, but it is helpful to measure the blood pressure in the patient who have the uncontrolled BP. Next is the some biochemical analysis. In the some biochemical analysis, we have a very small and user-friendly stat sensor express creatinine, which is of the weight of 75 gram, which can calculate the creatinine at the home, which is less than 600 micromole per liter. Now, a number of other companies and universities are currently developing micropad and microcell for the sensing of potassium, phosphate, urea creatinine level with a great promise for the use in the home setting. So we can calculate this level in home for the patient of especially CKD. And last few slides in the diabetes, as we all know, the diabetes is the most common cause of the CKD, and the good glycemic control is very important factor in the renal disease progression. So here again, the point of care technology has been used. We have a lot of glucometer which are available in the market. We use this technology. Now, there is a large number of small, light, and simple to use glucometers commercially available that are licensed for use at home. Now, evidence supporting their use exists in the general diabetes as well as the CKD diabetes populations. Now, the integration of the smartphone with the blood pressure and the glucose monitoring device is very important in the diabetic care in this patient. Now, DiaFit is a smartphone app that allows the integration and the storage of the diabetic patient dietary intake, physical activity, meditation use, blood glucose values, and the general well-being. So we can see their data and we can help them in the management. Now the physician can view this information and communicate with the patient by the app. So next is the anticoagulation. Now few of our patients are also on the anticoagulant. Now, anticoagulation is commonly required in the CKD patient, and the anticoagulants are among the most prescribed drug in this patient population. Now, standard of use of direct oral anticoagulant in the general population and the pharmacodynamic properties of these drugs limit their use in the advanced CKD, with multiple guidelines suggesting warfarin to be the safer choice in this patient. So there are small number of INR monitors available for the home use also. However, the majority of studies support use at the home conducted with the CoaguCheck, which is available by the Roche Diagnostics. Now, this CoaguCheck XS is a very small device which has a weight of 127 gram, and it provides the amphometric determination of the prothrombin time and INR using the capillary blood in less than 1 minute. And it can calculate the INR range from 0.8 to 8. So these are the available methods for the management of hypertension, diabetes, anticoagulants, and creatinine and tacrolimus. And what is currently in the development? So currently in the development is the analysis of peritoneal fluid as well as saliva. So new POC technology is available for the diagnosis of the peritonitis in the peritoneal dialysis patient, from which we can diagnose the peritonitis in this patient at the very early time. Now, another interesting new approach is the saliva POC testing. Now, there is available is the urea dipstick testing, which has been used for the detection of advanced kidney failure in the rural Malawi in one of the studies. So we have now the handheld analyzers and the smartphone as a laboratory. So the POC testing by capillary finger prick microsampling is already widely used by the nephrologist in a range of settings, such as inpatient care, in the acute clinics and others, and a large variety of devices are commercially available. Typically, this approach is used to measure the electrolytes, urea, creatinine, glucose, hemoglobin, hematocrit, and the bicarbonate, which help to simplify the treatment for their patient and make it convenient. So these are the point of care testing at the home is available. One is the urine dipstick. We have already discussed. to calculate the albumin-urea, detection of UTI, and the monitoring of the glomerulonephritis. In development is the saliva testing, especially for the PD fluid to detect the peritonitis at early as possible. Next is the capillary microsampling for the detection of serum creatinine, tacrolimus, and the COVID antibodies. And now there is a handheld devices and smartphone we can use for the management of diabetes and the hypertension. So these are the limitation and the pitfall of the point of care testing at the home. So what problems we can come across, and these are the suggestions to mitigate against them. So first is the problem is the digital divide. So we need to ensure the clinical pathway also work without POC testing at home technology. So other problems we face with the use of POC testing at home is the language barrier. Patient with a visual impairment and other disabilities cannot use these methods. Patient could manipulate test results. They can provide the sample of somebody else and can manipulate the test results. Next is the speed of the internet connection is important, which is very poor in some rural areas. Then connectivity to the electronic health record is needed in these patients. And next is the reliance on the equipment such as mobile phone for these things is required. So these are the barriers for the use of point of care testing at the home in the present time. So finally, the conclusion is the point of care testing is increasingly attractive to the nephrologist and integrates the well into virtual reviews within a changed landscape of outpatient service. Cost efficiency, patient convenience, and concern around the climate change have acted as drivers for this development as a part of increased virtual care provision overall. Now, some key laboratory parameters that we rely for decision making are already available by POC home testing, and the list will certainly grow in the near future. Thank you so much.
Thank you, ma'am. Dr. Vinay, Dr. Gautam, any questions?
बहुत बढ़िया है.
Thank you, Dr. Suman, and for a very enlightening talk. And actually, you summed up very well. That includes all sort of point of care testing we were discussing since first presentation, then Dr. Lobo's presentation, Dr. Ranajit, Dr. Gautam, and Dr. Sunil Karant, and everybody. So I think I don't know how many of participants have listened to these talks. I hope they have had joined here and come prepared on the 10th of March. I hope they had already listened it. So we'll meet again on 10th of March. Till then, I don't think there is any question in the chat box or so. So if Dr. Gurkirat allows us, then we'll close the session. Everybody must be in a mood to go and celebrate Holi.
Yes,
Dr. Gautam, sir.
Sure, sir. पक्का बिल्कुल.
Dr. Lobo, sir, कुछ any comment?
No, I think fine, unless there are any questions from anyone.
No questions in the chat box.
Right, sir. Right. Okay, sir.
Okay,
so we'll close the session.
Good night.
Thank you, everyone, and we'll meet.
Thank you. Happy Holi.
During the conference.
Thank you, sir. Thank you so much.
Thank you.
And during the workshop on 10th.
Okay,
Thank you.
bye.
Okay, bye.
Okay, good night,
Bye.
sir. Thank you for. Thank you.